Good evening. Our class again, Nobi Pulmonology Master Class, and every time we decide the topic of the class depending on our inputs, which comes from all over India and abroad. I didn't know suddenly there was a spark in interest on sarcoidosis. Actually, I was being ready with bronchiectasis, but again there was overwhelming request to consider sarcoidosis. And be it that, so it's sarcoidosis 23. What do we see sarcoidosis on 2023? Diagnosis and management. A little about our NOBI again. NOBI, National Allergy Asthma Bronchitis Institute. I am the medical director. It started its journey since 2008, 1st July, birth of legendary Dr. Bidhan Chandra Rai. And since its inception, NOBI is working on clinic, research, and teaching. Previously, we had our classrooms, which are very popular throughout the country. We did several classes at several peripheries and throughout everywhere. Delhi, Cochin, Bhubaneswar, everywhere we did. Chennai, we did classes. Since the pandemic, we have shifted to online. Fortunately, and it's a great joy and pride for us that our online classes are on high demand. We get audiences from all over India and abroad. So this time we are on sarcoidosis, and just a point, it's not a webinar. We know there are a flurry of webinars around, and that's why we do it on a Friday, not to get into any competition with other webinars usually on Saturday and Sunday. And it's a classroom approach. You are very keen on that. That means it's a classroom from the very basics, then going up, the confusions, the controversies, clearing them all, and ultimately the updates and everything suited to postgraduate students before and after examination. Today we have two very good next generation, I should say. Actually, for me it will be next generation faculty today. Dr. Sahajal Duria and Dr. Sudeep Ghosh. Sahajal is Associate Professor, Pulmonary and Critical Care Medicine, PGI-MER, Chandigarh. He did his MD from All India Institute of Medical Sciences. He has shown his interest in research and publications on diffuse parenchymal lung disease and sarcoidosis and others, of course. Welcome, Sahajal, to our Novi Pulmonology Master Class. And Sudeep Ghosh, he is now Assistant Professor, All India Institute of Medical Science, Kalyani, and he is a very good researcher and speaker. And again, welcome, Sudeep, in our monthly master class, this time on sarcoidosis.
Thank you, sir.
Yes, thank you both to be here. And we'll give the thank you later, but again, we have the logistic support from Lupin. At present, there is Pranali. I think others are there, including Santosh and higher up. So, welcome you all. Now, I was just going through the files, my old files. I don't keep the files very much right now, but I had old files. And I remember in early 80s, there was some joke about sarcoidosis. One of my teachers said, there is one disease where there are more experts than patients. And it was sarcoidosis. And then this was the first report, Ghosh and Chakraborty, first report from Bardwan, West Bengal in India, Indian Journal of Pediatrics 1953, and then Ghosh and Chakraborty again, Bulletin School of Tropical Medicine 1956. We took part in the conferences of World Association of Sarcoidosis long back, and then from Kolkata there was interest in sarcoidosis and literature. I was just going through some previous cases. One case was this, round about 2000 as I remember, 47 years male, non-smoker, non-diabetic, normotensive, cough with scanty expectoration 6 months, mind it 2000. Tuberculosis was very much a DD that time, even now. Streaky hemoptysis, but shortness of breath on moderate exertion. Sputum may be repeatedly negative in smear and culture. That was AP, 47 years male. This was the X-ray. Now for the students, if you look keenly, this X-ray itself has many features to suggest sarcoidosis. Of course, our mind picture of sarcoidosis is a female, middle-aged female, say 20 to 50 year age group. But again, males are not exempt from sarcoidosis, and generalized diffuse pulmonary parenchymal opacities with preservation of lung volume is something we suspect sarcoidosis. SSE was done, it was just high, others were not much remarkable, and all the collagen vascular markers were done and it was negative. Spirometry, well, not that bad. FEV1 good, FEV1 FBC above the normal range. DLCO was 64% predicted. ECG echocardiography were normal. This was the, remember, this is the picture. So don't expect as good as now. This is the picture, and that too from a government sector hospital in 2000. Another 10-10-2000. Another, and transbronchial lung biopsy was done. Non-caseating granulomatous inflammation, the possibility of sarcoidosis has been considered. Actually, what we did every time, we discussed with the pathologist when he sent the sample that we have this DD, please consider. And lavage and tissue culture for mycobacteria were negative. Spirometry after 6 years, you can see again not that bad. And SSE high, okay, not that much. This we made a graph, serial spirometry. As you can see, it was a bit downhill. It's not straight. Bit downhill, but not that relentlessly progressive as you see in, say, idiopathic pulmonary fibrosis. This was the X-ray in 2006. He was one executive of West Bengal government, civil officer. This was the progression over the years. As you can see, he was on treatment, initially on steroids and most likely on hydroxychloroquine as well. And over the years, there was some progression, but again, still, we could stop the medicines, steroids, altogether. Probably in 2006, he's still okay and alive. So, just some careful restrictions. Otherwise, she is living a normal life till now. This one became a little different. He was a doctor and started with sweating, lethargy, weakness, low-grade fever, arthralgia. That means a bit of extrapulmonary features. X-ray done, adenopathy, treated with antibiotic, antimalarials, and someone gave steroid, and it resulted in dramatic improvement. But again, someone put him on ATD as well. This was the CT scan in November 2000. This is in 2003 and this is in 2004. As I said, a doctor, he was very keen. Actually, his father was also a doctor. But what happened, this prolonged course of steroids, hyperglycemia, and in 2004, avascular necrosis of the left femoral head. That's why I remember this case particularly. X-ray, and as you can see, avascular necrosis of left femoral head. Just I'll round up with another case. This is a female and presented with neuropsychiatric manifestations. See, when we first saw her, she was not in respiratory department. She was in emergency admission of general medicine when we were referred to see the patient, and she presented with neuropsychiatric manifestations, but this. So this was very characteristics. The age, 32 years, non-diabetic, normotensive, and maculopapular skin lesion over necks, trunks, and proximal portions of the limb for 2 years. This was the history. Another view. Another view. This was the X-ray. We did a skin biopsy. Histology compatible with sarcoidosis. And we did transbronchial lung biopsy as well. Granulomatous inflammation consistent with sarcoidosis. There is a long history because this lady was not very adherent to treatment. Whenever she got well, she was lost to follow-up. For example, that time we lost her for 3.5 years. She came back, she had already been pregnant and get a normal female baby. And ultimately, she was put on OCS and then methotrexate. She still sometimes comes, sometimes drops her from our records. So she is still there, alive, and more or less quiescent in the activity of sarcoidosis. There are many stories. I remember another about 37 years male presenting with arthralgia and erythema nodosum, and then pleural effusion, out of all pleural effusion, first left, then right. And after all workup, it was diagnosed as a patient of sarcoidosis. So the variety is immense permutation combinations. The diagnosis is always a constellation of symptoms, signs, and investigations. So from now here, I'll request Dr. Sahajal Duria to start the diagnostic part of sarcoidosis. Dr. Sahajal Duria, please.
Thank you, sir. I'm not able to share the screen. Is the admin there? I'm not able to share the screen. The icon is not clickable.
Hey, the screen টা বন্ধ হয়েছে কিনা দেখ। Pranali?
It is.
Yes, sir.
Share the screen of Sahajal.
Okay.
Yeah, I think. Is it visible now? Is my screen visible? Okay. Can I start now? Am I audible and my screen visible?
Yes, sir. You are audible and screen is visible.
Okay. Then I'll start. So
Yes.
good evening, everybody. I thank Dr. Ghoshal, Dr. Rajadhar, and everybody in the team to give me an opportunity to interact with the audience here. So I'm going to talk for about 20-25 minutes on the diagnosis of sarcoidosis. And I'll mainly discuss the principles, not go too much into the specifics. So I'm going to cover certain topics in the form of some questions. So the first one is, what is sarcoidosis? When to suspect sarcoidosis? What is the diagnostic approach? What are the initial investigations? What screening tests for extrapulmonary involvement should be performed? When and how to get a tissue diagnosis? And what are the major differential diagnoses and how to differentiate? So the first question, after this lecture, the postgraduate students must be able to answer these questions which I have enumerated. The first is, what is sarcoidosis? What is the definition? So the definition of sarcoid is, it's a systemic granulomatous disorder of unknown etiology. So three things here are important to understand, and they will help you in the diagnostic approach. So one, that it is a systemic disorder. Two, it has a granulomatous pathology, and it has no known etiology. So if you remember these three things, you'll be able to diagnose a patient with sarcoidosis. So when to suspect sarcoidosis, especially pulmonary sarcoidosis? So whenever there is intrathoracic involvement of the lungs or the lymph nodes, it becomes a part of pulmonary sarcoidosis. Even the lymph node sarcoid within the thorax is considered to be part of the pulmonary sarcoid. So it can present with a subacute onset of fever, cough, loss of weight, loss of appetite. So any combination of these symptoms may be there. We can call it a TB-like presentation, tuberculosis-like presentation, because TB has similar features. It has a subacute onset of fever, cough, and loss of appetite and weight. Then it can present with chronic cough and dyspnea. So maybe a cough for more than 3 to 6 months, slowly progressive dyspnea over months to even years. This can be considered an ILD-like presentation, because chronic dry cough and shortness of breath are classic symptoms of an interstitial lung disease or a diffuse parenchymal lung disease. So these are the two major presentations of pulmonary sarcoid, and other important symptoms in chest involvement are chest pain and fatigue. Although fatigue is considered an extrapulmonary symptom, but sometimes it may be a presenting feature without any pulmonary symptoms, and you might just find pulmonary findings. So there can be certain extrapulmonary presentations. So there may be skin lesions in the form of lupus pernio, which is a very characteristic facial lesion, but lupus pernio is extremely uncommon in actual clinical practice. So even our dermatologists have seen at best a few cases, despite our center being a sarcoid referral center and this region being very endemic for sarcoidosis. But papules, as Dr. Ghoshal also showed, so there may be papules, there may be maculopapules, there may be nodules. Those will be more common findings in skin sarcoid. Arthritic presentation can be there. So the patient can present to the rheumatologist, and finally he or she might be diagnosed with Lofgren syndrome. So what is Lofgren syndrome? The classic triad, when it was initially described, consisted of fever, erythema nodosum, and bilateral hilar adenopathy. But then it is also considered a tetrad if you add migratory polyarthritis to it. So you can remember it by just remembering the few letters of Lofgren. So L is lymphadenopathy, F is fever, R for arthritis, and EN for erythema nodosum. So you can remember these four findings or tetrad of the Lofgren's syndrome. So sometimes it is a question. So if you are asked a triad, this is the triad. If you asked a tetrad, so these three plus migratory polyarthritis is the tetrad of Lofgren syndrome. Sometimes patients may have weakness, anorexia, nausea, and constipation, which can all be due to hypercalcemia. And there can be other features also like tingling, polyuria, other features of hypercalcemia might be there. Hypercalcemia can also cause acute kidney injury. And rarely there can be granulomatous involvement of the kidneys, which is kind of rare. More commonly, AKI would be caused by hypercalcemia and sarcoid. A red eye a blurring of vision, mild eye pain might be due to uveitis. Then there may be other ocular manifestations, which I think there is a question on it, so we can discuss it there. But I am discussing the most common extrapulmonary presentation. So there may be asymptomatic hilar adenopathy, which may be detected during a routine medical screening. And this is also a reasonably common presentation in clinical practice, especially when medical fitness examinations are done for jobs, for visa purposes, etc. And there might be heart failure or arrhythmia in cardiac sarcoidosis. Then neurosarcoid, another important entity, which is not that common, but it can be a mimic of so many other neurological disorders. It can present with cranial neuropathy, it can present with brain involvement, spinal involvement. And there also tuberculosis is a close differential. So we come to differential. So what are the differentials? As you must all be knowing, tuberculosis is the #1 differential diagnosis. In fact, as Dr. Ghoshal also showed, that initially it was thought that sarcoid does not exist in our country. Everything is tuberculosis. But slowly people realized with the efforts of our old teachers and researchers that even our country being tuberculosis endemic region, still there's a lot of sarcoid, especially in certain regions. And there may be certain genetic factors which may be causing sarcoidosis. So tuberculosis, the bacteria of tuberculosis and its antigens might be an inciting factor for sarcoidosis in some of the patients. There are other microbiologic entities or microbes which can also lead to a sarcoid-like reaction just because that antigen is present. For example, Propionibacterium, and there are other so many microbes which are associated with sarcoid. And then other granulomatous disorders. So there is a whole list of numerous granulomatous disorders which might be present. I'm not going to go into that list. You can refer it in major textbooks of pathology or even medicine. And then other interstitial lung diseases may be an important differential, especially if there is an ILD-like presentation. Amongst the ILDs, I would say hypersensitivity pneumonitis is the one which most closely mimics sarcoidosis, because here too we see upper lobe involvement. We can have preserved lung volumes. There may be airway involvement. So all these three features are also features of a chronic case of sarcoidosis. So the diagnostic approach, as I told you, the secret lies in the definition. So again, I'll reiterate that sarcoidosis is a systemic granulomatous disorder of unknown etiology. Systemic means involvement of 2 or more organs, sometimes even a single organ. And there may be systemic energy, that is non-reactivity to the tuberculin antigen. And there may be other antigens which you might test, but we do the tuberculin skin testing or the MAN2 test, to which there may be energy, that is non-reactivity. Then the second part is granuloma. So it is important to demonstrate granulomas without significant necrosis in the affected organ. It's also called non-caseating granuloma. But actually, some pathologists do not agree with the word caseation because caseation is a gross pathology term. In microscopic pathology, certain pathologists won't use this term. And there you can see dirty kind of necrosis. If you have tuberculosis, you'll see some kind of dirty necrosis with a lot of nuclear debris. So if that kind of necrosis is not present, then it is called a non-necrotizing granuloma. And that is the characteristic feature of sarcoidosis. Non-necrotizing granulomas can also be found in tuberculosis, but granulomas with major areas of necrosis are not found in sarcoidosis. The third part is being of unknown etiology. So one must exclude known causes of granulomatous inflammation. As we discussed, TB is the most important differential in our country, so that is to be excluded. And there can be other granulomatous disorders, like you can have chronic beryllium disease, which is a very close mimic of sarcoidosis. If there's beryllium exposure, there can be other microbes which can cause granulomatous inflammation. There can be other inhalational agents, inhalational injuries which can cause. So there's a whole list of things which can cause granulomas. So organ involvement with sarcoid, the most common involved organs are lung and lymph nodes, which are involved in 90% of the cases. The eye, skin, and joints, these may be involved in 10 to 20% cases for each of these organs. So 10 to 20% in the eye, 10 to 20% patients might have skin involvement, 10 to 20% can have joint involvement. Liver, kidney, and heart, about 5 to 10% each. Hypercalcemia and hypercalciuria can also occur in 5 to 10%. And bone marrow may be involved in less than 5% of the patients. And these figures vary across various regions, various studies. So Japanese may have a different profile than, say, Northern Europeans, and they have a different profile than, say, Black Americans. So these percentages of organ involvement, especially extrapulmonary organ involvement, can vary across populations, but lung and lymph nodes are the most common across the world. So the initial investigations would be, first, you'll get a chest radiograph. Now, who orders it depends on the presentation. If there are respiratory symptoms, that bring the patient to the pulmonologist. Most often, a pulmonologist would always order a chest radiograph for any patient with a respiratory system involvement or symptom. Extrapulmonary presentation, if it is there, it will depend on whether the other specialist suspects sarcoidosis or not. So sometimes this kind of sarcoidosis may remain undetected. For example, hepatic sarcoid. If you don't do a biopsy, if somebody does not suspect, then he or she might not get a chest X-ray done for the patient. Cardiac sarcoidosis is often missed because arrhythmias and heart failure may be there, but the cardiologist might not suspect sarcoid. So it is very important that other specialists from different subspecialties also have an index of suspicion for sarcoid whenever they come across those kind of manifestations. So now coming on to staging stages. So staging of sarcoid basically initially was proposed on the chest radiograph, but stage does not mean that there'll be a consecutive progression from stage 1 to 4 in all patients. A patient might directly present with a stage 4 disease to you. A patient might have stage 1 disease, which never progresses, but rather resolves completely. Or sometimes you might see that a stage 2 disease was there, which progresses to stage 3 and then to stage 4. So what are these stages? So stage 1 is bilateral hilar lymphadenopathy. One means only one thing involved, which is the lymph node. So bilateral hilar lymphadenopathy. Stage 2 means two things are involved. 2 meaning bilateral hilar adenopathy and the lung. So in the lungs, you can see these nodules and some reticulation, and it is all in more in the peribronchovascular region. So it is radiating from the hila. So this is called stage 2 disease. Stage 3 is more advanced, where the lymph nodes have disappeared, but only the lung involvement is there. And this is a worse stage than stage 2. In stage 2, both things were involved, but it is mostly seen in an earlier kind of timing in the natural history. Stage 3 is no lymph nodes and only lung. So this is a more more serious kind of sarcoid because it generally progresses. And stage 4 disease means there are signs of fibrosis. So there may be volume loss, there may be these kind of bands which look kind of pull the hilum up. So this hilum is pulled up, and there may be major volume loss. Here there is not much of a volume loss, but there can be X-rays where there's a lot of volume loss. The diaphragms may be tented, there may be complete lobar collapse, there may be other such features of fibrosis. So what are the initial investigations for pulmonary sarcoid? The first, after a chest X-ray, the first thing that we'll do is a contrast-enhanced CT plus a high-resolution CT. Contrast-enhanced because you need to look at the lymph nodes very closely, and high-resolution or a thin-section CT so that you can look at the pulmonary parenchyma. Nowadays, we do a volumetric CT scan and do a thin-section or high-resolution reconstruction. Previously, it used to be just an HRCT. Nowadays, it is volumetric CT with high-resolution reconstruction. The other important investigation would be spirometry to look at the basic lung function. TLCO is desirable if available. Actually, you must do in all patients if available and very standardized. Otherwise, there may be a lot of variability in the technical part, and then it might just confuse you. So depend more on spirometry. And if you have a very good DLCO, then go for it. Lung volumes are optional. If you you want to study a patient in detail, or you want to do a kind of a research study where lung volumes may be done in all patients, or if you have the facility, you might do it. But the basic way that you monitor the patient will be through a spirometry in most cases. If you have a mixed obstructive restrictive defect, then lung volumes may be helpful. Tuberculin skin test should be done in all patients, as TB is always a differential, and a highly positive MAN2 will help us in differential diagnosis. And serum ACE levels again would not be mandatory, because it is not of much diagnostic potential unless it is very much raised, 2 times, 3 times than the upper limit of normal. But if it is just above the upper limit of normal, then you cannot be really sure that it is sarcoid. And sometimes in some patients, it helps in gauging activity, but again, it's not a great marker. It will not work always. So it is your wish whether you want to do it or not. But we do it in our center because we keep on doing some studies. So we keep on collecting that data. So on CT, you'll see these kind of nodes. So they may be very drastic nodes. I'm showing you a more subtler presentation. So this is right paratracheal node. This is the SVC. This is the aorta. This is the carina, and this is just below the carina. There's a subcarinal node. There may be large potato nodes here in the bilateral hilar region, which is more typical, but I'm showing you a more subtle case. Beware of hypodensity. So in this particular case, you have a large asymmetric lymph node where there is a large hypodensity or signs of which suggest necrosis. So here, this patient had actually tuberculosis and not sarcoid. So if you see a lot of asymmetry or necrosis, then you should think of tuberculosis first. CT findings in the pulmonary parenchymal findings would be, there will be this kind of peribronchovascular involvement. So this is a classic peribronchovascular or perilymphatic involvement with the thickening of the septa and nodules. So it's a nodular thickening. This is more clearly seen. So these are bronchovascular bundles which are thickened, and this is kind of a nodular thickening. There are nodules all over. So these are called perilymphatic nodules or peribronchovascular nodules. So then you move on to tuberculin skin test. MAN2 is the most common method. It is practically still the most useful test for demonstrating energy in patients with sarcoid, especially in our country. It has a very important role. So we generally use MAN2 to diagnose sarcoid rather than TB. That is, a negative MAN2 will support a diagnosis of sarcoid, but a positive MAN2 is there in 30 to 40% of the Indian population, even normal individuals. So a positive MAN2 will not always point towards tuberculosis if you don't have the clinical presentation. So only 10% of patients with sarcoidosis have a TST which is more than 10 millimeters. So 10 millimeter is the kind of mark we use. And the interferon gamma release assays may be positive in 4 to 34% of patients with sarcoid, depending on different populations. So in high TB burden countries, there'll be a higher positivity rate, and that may, so IGRA may be positive in sarcoid in a higher proportion because there may be some latent TB, but the presentation may be absolutely like sarcoid, and it might respond to even steroids. So IGRA becomes a test for latent TB only, while MAN2 has possibly a more kind of differentiating value for TB and sarcoid. The ACE levels elevated in 75% of untreated patients. Again, the cutoffs are very variable. The assays are variable. It has to be, the cutoffs have to be calculated from the population that you are testing and the mean of the population. If the ACE is raised 3 times above the mean, then it is considered to be more sensitive and specific. In a recent meta-analysis, the sensitivity was found to be 60%. Specificity was reasonably high. It was 93% in a recent meta-analysis. But again, there are issues with the cutoffs and with the assays. So it may be useful sometimes for diagnosing relapse. So if you have a documented raised level in the initial illness, then it falls down to normal value. And then if it is again raised, say 2 to 3 times, then it might, you might consider a relapse, especially when there are other organic features or organ involvements which point towards a relapse. But by itself, you cannot rely on ACE for deciding either the diagnosis or the relapse. Sorry. So conditions with increased ACE levels. So asbestosis, beryllium disease, coccidioidomycosis, diabetes mellitus, Gaucher's disease, HP, silicosis, tuberculosis, all these can also have increased ACE levels. So it is not always specific, depends on the clinical scenario. So what do you screen? Because there may be extrapulmonary involvement. So there are certain screening investigations for extrapulmonary involvement as provided in the recent 2020 guideline for diagnosis of sarcoid, the American Thoracic Society guideline. So I have made it a bit simple to remember. You just remember A, B, C, D, E, F. So A means alkaline phosphatase to look for granulomatous hepatitis. B is blood counts to look for bone marrow involvement, which is very rare, but anemia, leukopenia might be there due to other reasons. C for creatinine and calcium to look for renal involvement and hypercalcemia. Vitamin D is not to be done in all cases. If you are thinking that you want to supplement vitamin D, then you should do both 25-hydroxy and 125-hydroxy, because 125 25-hydroxy may be low, but if 125-hydroxy is high, it might be produced by granulomas, and such patients may develop hypercalcemia with minimal vitamin D supplementation. So you should be very careful while supplementing vitamin D and rather avoid it if it can be avoided during active sarcoid. The eye examination important for ocular sarcoid ECG to look for PR interval. Prolonged PR interval is an important finding. There may be arrhythmias. Echocardiography may be done in patients, but may not be required in all patients. If you are suspecting, then echo may be done. And full LFTs, again, is a relative indication. You might not need the full LFTs, but if you do it as part of your routine workup, you can do it. We generally get full LFTs. So diagnostic evaluation of suspected extrapulmonary disease, like other things like cardiac sarcoid. So cardiac sarcoid, the investigation of choice would be a cardiac MRI. If MRI is not available, do a PET. If you're suspecting pulmonary hypertension, first do a transthoracic echo. If it is suggestive, do a right heart catheterization. If it is not suggestive, again, you might go for a RHC if you have a high index of suspicion, because echo might not be sensitive and specific for pulmonary hypertension. The second principle is the demonstration of granulomas. In the West, in typical presentations such as Lofgren's, biopsy may be avoided. That is what the guideline tells us. But our practice is to attempt tissue diagnosis in all, because tuberculosis is a significant differential in most cases of sarcoid. And even an arthritic presentation can occur with tuberculosis. So it should be done in all cases in our country. So what to biopsy? Choose the most accessible site. Skin lesions, you can choose if they have macules, papules, nodules, but don't biopsy erythema nodosum, because it's a panniculitis reactor. It's basically a reaction to the antigen, and it presents with panniculitis. There'll be no granulomas there. Peripheral lymph nodes, again, can be accessed easily. Conjunctival sampling has been described, but normally we don't do it in India for sarcoid diagnosis, as far as I know. And then you can do a bronchoscopic procedure like a bronchoalveolar lavage, endobronchial biopsy, transbronchial lung biopsy, or TBNA, transbronchial needle aspiration. So for bronchoalveolar lavage, the most involved segment should be chosen. So it may be the middle lobe or lingula, where the return might be good. Occasionally, 2 or 3 different sites can also be chosen to have high representation. The procedure is basically you wedge the bronchoscope into the appropriate segment, inject warm physiological saline, 260 ml aliquots, wait for some time, apply gentle section or aspirate with a 20 ml syringe, collect return into a mucus trap. Recovery of at least 25% of fluid should be there. I'll not discuss this too much. This is more procedural. But the important thing is lymphocytosis is common with sarcoid. And CD4, CD8 ratio is the one which will help you in this, differentiating, say, sarcoid from hypersensitivity pneumonitis, because HP also has lymphocytosis. But the problem here is that there are different cutoffs. Some people have used a 2.2 cutoff for this ratio, up to 4. The most used has been 3.5, the ratio of CD4 to CD8. But again, the sensitivity is poor, 70%, specificity is again 83%. So it's not a good diagnostic test. Bronchial mucosa may be abnormal on examination, bronchoscopic examination in 30 to 40% cases. So if you have abnormal mucosa, you might find granulomas on endobronchial biopsy in 50 to 75% of cases. If you have normal mucosa, even then 30 to 50% cases might show granulomas. This is transbronchial lung biopsy, where you go deep into the bronchi and pierce the bronchiolar wall. It is basically a blind procedure unless you are using fluoroscopy, which can give you some guidance. And then you pinch the lung tissue between the branching distal airways. So this is the way the forceps reaches the peripheral part. and samples the lung parenchyma. Then you have conventional TBNA, where you use the CT scan to localize the nodes, and then by the anatomic location, you do a conventional or the so-called blind TBNA through a flexible bronchoscope. This is the EBA scope, which is the most definitive method to access mediastinal lymph nodes in suspected sarcoid. And again, I'll not go into detail, but basically this is the scope where you can, this is the ultrasound probe, you can visualize the node through the ultrasound, and then this needle will puncture the lymph node and give you FNA, basically aspirate from the lymph nodes. So what are the average yield of procedures? This slide is important. Average yield of procedures in sarcoidosis. So BAL has a poor sensitivity and specificity. Basically, it may be useful to exclude TB, especially if you have some central lobular nodules. Endobronchial biopsy, average yield would be 40%. There may be various ranges, and it may differ from center to center, place to place. But average, I would say 40%. CTBNA 60%, TBLB would be 70%. EBUS TBNA average would be 80%. If you combine the three procedures, CTBNA, EBB, and TBLB, it might be about 85%. And if you have EBUS TBNA combined with EBB TBLB, so if you do all the three important procedures, then you can reach a very high yield of 93%. So the third principle would be to exclude known causes of granulomatous inflammation. And again, this whole list is there. I'm short of time, so I'll not go too much into it. But if you have lung granulomas, TB will be the major differential. Atypical mycobacteria may be there. Fungal granulomas may be there. Pneumocystis, mycoplasma, hypersensitivity pneumonitis. So there are various features attached to these various kind of granulomas. For example, if you have a hypersensitivity pneumonitis, you'll have very loosely formed granulomas by few epithelioid cells and one giant cell. While in case of sarcoidosis, they are very well-formed granulomas. Vaginous granulomas will be very different from sarcoid. So there can be very specific features which point towards certain differentials. So always avoid the pitfalls during sarcoid diagnosis. Don't think I'm the big boss and you just look at the X-ray and say this is sarcoid and nothing else. So there is a difference between judgment and verdict. So basically you might judge a patient to be having sarcoid or TB, but it's better to go for all the investigations and not pronounce a verdict just on the basis of a chest X-ray. So these kinds of chest X-rays we have come across in various patients of sarcoid and TB. And sometimes I don't even remember that what patient, finally was the diagnosis in these particular X-rays, because they are so confusing. A unilateral presentation will be uncommon with sarcoid, but this kind of presentation will also be uncommon with TB, because TB will have some upper lobe involvement in the other lung also if one lung is so involved. So it might be very difficult to really differentiate just on the basis of these X-rays that whether it is sarcoid or TB. For example, this patient did have sarcoid. This patient did have TB, where you can see certain. For example, if you have a lot of nodules all over the place and the patient is not too sick, he's walking about, then you might think that this is more of sarcoid, because a tuberculous involvement on the right-sided X-ray, this kind of extensive tuberculous involvement will make the patient very sick. So on the CT also, importantly, you might not be able to really make out whether it is TB or sarcoid. So it is always important to do all the investigations. So there are certain features that point towards sarcoid, certain features point towards TB. I would request you to please go through this older article, a decade back, by Dr. Dheeraj Gupta, but this table is very useful for the features that help you differentiate between sarcoid and TB. So, for example, if there's high-grade fever for a prolonged time, you might think more of TB, but fever can also be seen with sarcoid. If there is a lot of weight loss, again, TB, more of a differential, but can occur with sarcoid. Extrathoracic lymph node, cervical lymph nodes are more common with TB rather than sarcoid. So there are various features which help you to differentiate between TB and sarcoidosis. So this, you can just note this down or take a picture of this particular citation, and you can go through this table and even the entire article. So if you do a biopsy, as we discussed, necrotic versus non-necrotic, or necrotizing versus non-necrotizing granulomas, and that might finally help. And if you have a microbiologic evidence, for example, in the form of acid-fast bacilli, or an automated PCR like gene expert, then you might be better off in finally pronouncing the diagnosis of tuberculosis. So pathological features which favor sarcoid would be numerous granulomas, which are compact and tightly packed, non-necrotic, perilymphatic, with a sparse lymphocytic infiltrate around, and negative for cultures and stains for various microbes, including acid-fast bacilli. And then extrathoracic involvement would be more common with sarcoid. What goes against sarcoidosis? If there are few granulomas or no granuloma, if they are loosely organized, if they lack a lymphangitic distribution, if there is robust surrounding lymphocyte infiltrate, so that is more common with TB. Stains and cultures for microbes positive, so that means there is a known etiology, and then it is not sarcoid, it is basically that particular differentiation. And then if there is only extrathoracic involvement, that also goes slightly against, but there can be isolated cardiac involvement, isolated neurological involvement. Those are seen in clinical practice, but they are rarer. So this is one of our studies where we looked at expert for differentiating between sarcoid and TB. So it had a 50% sensitivity, not a very good sensitivity, but specificity was 98%. So if you have an expert positivity, you can be very sure that this is tuberculosis. So even with a 50% sensitivity, this is a good test, because at least in 50% of cases, it will give you a very good confidence in your diagnosis. So basically just summarizing what we have already discussed. So if the clinical presentation is highly supportive of sarcoid, like Lofgren's, lupus pernio, Hereford syndrome, or bilateral hilar retinopathy with no symptoms, you may not go for a biopsy in the West. But I would say in India, we should still go for a tissue diagnosis, because sometimes you'll find expert positivity in such patients and the diagnosis will be very different. It will be tuberculosis. But if you have a consistent picture with sarcoid, then biopsy is recommended. If you do a biopsy, find granulomas, and the clinical presentation is supportive, then you make a diagnosis of sarcoid. If you don't find granulomas, then you might finally make a clinical diagnosis of sarcoid. But if you see, there is nothing called a definite diagnosis of sarcoid according to the 2020 guideline. It is always probable, because a cause might crop up even later. For example, sometimes it does happen still that you diagnose a patient with sarcoid, it proves to be tuberculosis after 3 months down the line. He or she develops, a pleural effusion, which is clearly tuberculosis. So it always remains a probable diagnosis. It never becomes a definite diagnosis, even according to the Western guideline. In our country, it is always probable, because TBs will always be a differential. So I'll just summarize what I have already discussed. So you should know common presentations of sarcoidosis, give special attention to several extrapulmonary features, and your colleagues in different specialties must be aware that there can be various presentations of sarcoid in the form of cardiac sarcoid, neurosarcoid, ocular sarcoid. Attempt a tissue diagnosis in all cases, at least in our country. Important differentials will be tuberculosis and interstitial lung disease and other causes of granulomas. And then a negative tuberculin skin test is sensitive for sarcoid. So it might have a 90% sensitivity, because 10% there may be 10% of the times it may be wrong. Then combine TBNA, EBB, and TBLB for tissue diagnosis. If you have conventional TBNA, you'll get an 85% yield. If you have EBUS TBNA and you combine it with EBB TBLB, then you can get a 93%, 95% yield. And always screen for extrapulmonary involvement. So we discussed the ABCDEF of extrapulmonary involvement, which should be done in all patients, because you might find some other organs which are involved which might need treatment. Thank you.
So, am I audible?
Yes, sir.
Okay, so Sajal, thank you very much. It was very comprehensive and exactly fits the bill of Nubi Pulmonology Masterclass. So thank you for joining us. And the last sentence was very meaningful, that the diagnosis of sarcoidosis is always probable. Exactly. All over the globe, and more so in India, because there is always the pretest probability of tuberculosis. But still, the workup is necessary, at least to spare the patient of unnecessary ATD in every case, and sometimes a combination of ATD with steroids without making a diagnosis or attempt at diagnosis. So the workup is important, but it's predominantly a clinical workup supported by laboratory findings, and frequently it's the constellation of the combinations that make us more sensitive for diagnosis of sarcoidosis. We have some questions, we will discuss that at the end. And I will now invite Dr. Sudeep Ghosh, Assistant Professor, All India Institute of Medical Science, Kalyani. Management part of sarcoidosis. Sudeep, please. Pranali, share the Sudeep's
Recorded.
Yes, sir.
Please.
Good evening to all. I am going to speak on the management of sarcoidosis. So, as we know, sarcoidosis is a granulomatous inflammation which is mediated by type 1 immune pathway. So, most of the treatment options are anti-inflammatory, which includes glucocorticoid, hydrochloroquine, methotrexate, MMF, azathioprine, and in refractory cases, we can use infliximab, adalimumab. In advanced stage of fibrotic sarcoidosis lung diseases, we can use oxygen and may consider for lung transplantation also. Many pH-directed therapies are also evaluated in pulmonary hypertension, and there are many parasarcoidosis symptoms like fatigue is one of them, and they are often tried with methylphenidate and modafinil, etc. So the most important concept in the management of sarcoidosis is when we should start treatment in sarcoidosis patient. If we look at the natural history of sarcoidosis, in 60 to 70% patients has a chance of spontaneous remission, but the remaining 10 to 30% patients goes into a chronic progressive phases. If we look at the lung involvement, the risk of resolution or the chance of resolution decreases when it progresses from stage 1 to advanced stage like stage 4. 80% of the stage 1 diseases has a natural history of spontaneous resolution, whereas only 30 to 35% patients of stage 2 or stage 3 may go into spontaneous resolution, but 5% patient progress to stage 4 disease. The sarcoidosis is also notorious for its relapse. When with a tapering or stopping of anti-inflammatory therapy, there is a risk of 30 to 50% of patients will have relapse in his lifetime. But the mortality rate is 1 to 5% in sarcoidosis patients. Now, what are the treatment indications in pulmonary sarcoidosis? The treatment of pulmonary sarcoidosis depends on balance of a minimization of risk of disability, mortality, or loss of quality of life in compared to the side effects or loss of quality of life due to glucocorticoid or other immunosuppressive therapies. Generally, we consider symptoms, severe or progressive functional impairment of lung parenchyma, and progressive radiographic infiltrations are considered generally as indications for treatment, but these are not well defined. So many studies predicted that high age, extent of fibrosis in HRCT scan, development of pulmonary hypertension, GAPS scoring, wall score, and stage 4 disease is associated with high mortality in sarcoidosis patient. This wall scoring is a new scoring system, which is a clinical radiological scoring system for predicting high risk or low risk of sarcoidosis patients. So when a sarcoidosis patient comes, in this scoring system, we calculate first composite physiological index from the formula given in the screen. So it includes measurement of DLCO, FVC, and FEV1. If the CPI, that is composite physiological index, is more than 40, that patient falls in a high risk or poor prognosis of sarcoidosis patient. If your CPI index is less than 40, then we should check the HRCT scan for two things. One is features of HRCT features of pulmonary hypertension, that is usually detected by looking at your main pulmonary artery diameter versus your ascending outer diameter ratio. If it is more than 1, then there is a high risk of having pulmonary hypertension or extent of fibrosis in HRCT scan. If your extent of fibrosis in more than 20%. So if any one of them is present with a CPI score less than 40, then this patient falls in high risk of sarcoidosis patient. If it is not, then that patient fall in low risk or good prognosis of sarcoidosis patient. Now, another indications of starting treatment in sarcoidosis is severe and progressive lung function impairment. Again, the cutoff of severe and progressive lung function impairment in sarcoidosis patient is not well defined. So generally these FVC less than baseline FVC less than 70% and DLCO less than 60% or a more than 10% fall in FVC or 15 to 20% fall in DLCO is considered to be a severe or progressive lung function impairment. These are usually considered to start treatment for pulmonary sarcoidosis. But the PET scan is also a very excellent tool to judge whether the patient needs anti-inflammatory therapy in sarcoidosis patients or not. If your PET scan shows high standardized uptake value, this is associated with more rapid and better regression of disease after treatments. The indications of treatment in extrapulmonary sarcoidosis is little bit straightforward. If your heart or eye involvement is there, or if a patient is having neurosarcoidosis, or there is calcium metabolism abnormality in the form of hypercalcemia or hypercalciuria, and patient is having disfiguring skin lesions, then these are the indications for anti-inflammatory therapy in sarcoidosis patients. Now we'll come to treatment of pulmonary sarcoidosis. Now pulmonary sarcoidosis, the corticosteroid remains the most widely used and well documented and most effective treatment for pulmonary sarcoidosis. Why? Because the study showed that this prednisolone systemic corticosteroid leads to a good clinical response with a reduced risk of clinical deterioration along with a radiological improvement. But the effect of corticosteroid on pulmonary function test parameter like FVC or FEV1 is not clear. It varies from studies to studies. The next important thing in treatment of sarcoidosis is what should be the dose of prednisolone. Again, the dose of prednisolone is unclear. Initially, we were using 1 mg per kilogram body weight of on 40 mg per day steroid or prednisolone in sarcoidosis patient. But subsequently, few studies showed that 20 mg per day is as effective as higher dose in improving FVC and pulmonary symptoms. Even in extrapulmonary sarcoidosis like cardiac sarcoidosis, a retrospective analysis found that there is no added benefit for giving more than 30 mg or 0.5 mg per kg per day of prednisolone in such patients. The next is how long we should treat with corticosteroid. Now, glucocorticoid treatment clearly has benefits in sarcoidosis patients. But again, there is a high risk of relapse after discontinuation, even with a prolonged treatment of prednisolone more than 2 years. The ideal duration is not well established, it varies from case to case. That is the recommendation from our ATS ERS statement. They recommend that we should start with 20 to 40 mg for at least 1 to 3 months. And if after clinical or radiological improvement, we should think about tapering the dose by at a rate of 5 to 10 mg per day every 1 to 3 months. then we should reach at a maintenance level of 5 to 10 mg per day, and we should continue it for at least 1 year. Now, if a disease or a patient on corticosteroid progressed with corticosteroid, or corticosteroid is not well tolerated, the side effects are so much that we have to change it or stop it, then we should think about second line therapy. There are many options in second line, like methotrexate, azathioprine, mycophenolate, hydroxychloroquine, leflunomide. So which one we should choose in pulmonary sarcoidosis? So this is a trial which compared methotrexate versus azathioprine in sarcoidosis patient, and this trial showed that clinical response in the form of lung function impairment or DLCO improvement, and even with a dose reduction of prednisolone, both the methotrexate and azathioprine is as effective as other one. But if we look at the side effect profile in that trial, that gastrointestinal side effect, hepatic dysfunctions are more or less equal in both the group, but the infection is significantly less in the methotrexate group. Although the withdrawal from the study drugs is more with azathioprine, but that was not clinically significant. So clearly, methotrexate and azathioprine is as effective as other one, but azathioprine has a bad side effect profile compared to methotrexate. The other option in sarcoidosis is anti-TNF therapy in sarcoidosis. So as from the pathogenesis of sarcoidosis, we all know that the TNF plays an important role in initiation, maintaining, and proliferation of inflammation in sarcoidosis patients. So many anti-TNF targeted therapies have been evaluated in the management of sarcoidosis, especially in refractory cases, where those patients who are not controlled or responded with corticosteroid, prednisolone, and or any other second line agent like methotrexate, infliximab, leflunomide, hydroxychloroquine, etc. So infliximab, adalimumab, golimumab, etanercept, and cetrorelix all are tried in sarcoidosis. So these are the two randomized controlled trial. Basically, they are these are the data from a single randomized controlled trial published in two different papers. One is for the parenchymal disease with extrapulmonary, and other is only the extrapulmonary sarcoidosis were analyzed. Where infliximab is given at 3 or 5 mg per kg at 0, 2, 6, 12, 18, and 24 weeks, and they are followed up for 52 weeks, and it showed that infliximab improved FVC, but there was no change in 6-minute walk distance. Also, in extrapulmonary cases, infliximab group had fewer organ involved with sarcoidosis at 24 weeks compared with baseline. Adalimumab also was tried in pulmonary sarcoidosis, especially in refractory sarcoidosis. It showed that it also improves FVC by 3% at 24 weeks and 2% at 52 weeks, and 6-minute walk distance also improved with adalimumab. So for summarizing the anti-TNF therapy, so the anti-TNF therapy is associated with small improvement in FVC, also improve function of extrapulmonary organs like cardiac sarcoidosis, neurosarcoidosis, may reduce steroid dose, but again relapse rate is high, as much as 50% of stopping this therapy, and these are associated with side effects of infection and allergy. So these are the flow chart for management of pulmonary sarcoidosis. If patients satisfied for the criteria of starting treatment, we should start with glucocorticoids, and if the patients continue to have disease progression or the glucocorticoid is not well tolerated, we should try tapering glucocorticoid and add the second line agent. The methotrexate would be the preferable agent. After that, azathioprine. If the disease progress even with this second line agent, we should think about adding anti-TNF therapy. Now, there are many controversies in management of pulmonary sarcoidosis. So, as we discussed that when we should start the treatment of sarcoidosis in pulmonary sarcoidosis is not well defined. So, we should urgently need an accurate risk stratification in pulmonary sarcoidosis. Also, what should be the optimal pulmonary function threshold integrated with the disease duration and risk assessment for progression in higher risk should be determined. It is also uncertain whether high risk disease is best managed with glucocorticoid monotherapy or combination therapy. Role of PET in rationalizing long-term treatment following initial stabilizations is also needs to be investigated in longer cohorts. And we also think about, or we should check whether we can detect any predictor of response to anti-TNF therapy in refractory sarcoidosis patients. So after pulmonary sarcoidosis, the extrapulmonary sarcoidosis, one of the most common organ involved is skin sarcoidosis. The skin sarcoidosis usually in milder cases usually managed with topical corticosteroid. But if the deformity or the skin are cosmetically important, then we should think about starting corticosteroid. But again, we have to remember that corticosteroid therapy is associated with a good amount of relapse in skin sarcoidosis also. So the addition of second line agent methotrexate hydroxychloroquine can be considered in a patient who is relapsed after tapering or stopping of corticosteroid or continue to have a disease progression on corticosteroid. Now, if the skin conditions remain unimproved or progressed on corticosteroid plus minus second line agent, we can think about adding anti-TNF therapy. This is an example where his lupus pernio, it's a skin change of sarcoidosis, remarkably decreased after infliximab therapy. So again, if you are starting with you start with topical glucocorticoid, if the cosmetically important skin lesions is there not responding to topical glucocorticoid, we should add prednisolone. And if we have to think about adding second line agent, probably hydroxychloroquine has a better skin protection in sarcoidosis than other second line like methotrexate, azathioprine. And in refractory cases, we can add anti-TNF therapy. The cardiac sarcoidosis is one of the important cause for mortality in sarcoidosis patient. Although the cardiac involvement is very rare, only seen in 2 to 5% of cases. But in Japanese population, this is the one of the commonest cause of death in sarcoidosis patient. Now, patient who is having cardiac abnormalities like arrhythmia or a cardiomyopathy or LV failure, glucocorticoid treatment is recommended with or without immunosuppressive therapy. And in refractory cases, we can think about anti-TNF therapy. Now, in 5 to 20% of sarcoidosis, nervous system is also involved. And again, the corticosteroid is the initial choice of therapy in CNS or CNS sarcoidosis also. But the relapse rate in CNS sarcoidosis with corticosteroid is not reduced with corticosteroid therapy. So additional of methotrexate with corticosteroid better in preventing relapse compared to the monotherapy. Again, in refractory cases, where the disease progressed even after glucocorticoid and methotrexate or any other second line agent, you may consider for adding infliximab in neurosarcoidosis patient also. Another important manifestation of sarcoidosis is ocular sarcoidosis. The ocular sarcoidosis, the involvement is most commonly uveitis. Adding systemic corticosteroid, and in refractory cases, there are reports where TNF therapy also can be used. So sarcoidosis associated fatigue is one of the parasarcoid syndrome, which is very difficult to treat with normal anti-inflammatory therapy like corticosteroid, infliximab, etc. So the ERS recommends exercise training, that is pulmonary rehabilitation and inspiratory muscle training, as a first line of therapy. If the patient continued to have symptoms, then we should add modafinil or methylphenidate. Another important aspect in managing pulmonary sarcoidosis patient is pulmonary hypertension. As we know, the pulmonary hypertension is associated with increased mortality in sarcoidosis patient. And if we look at the prevalence, it depends on the populations which are studied. In unselected clinical patients, 5 to 15% develop pulmonary hypertension. In advanced stage, where your dyspnea disproportional to the PFT, you may get a 50 to 60% of sarcoidosis patient to have PH. In a lung transplant candidate, 70 to 80% of sarcoidosis patient had PH. And the predictors or risk factors for development of PH in sarcoidosis patient and advanced lung disease like stage 4 disease, if your DLCO is less than 60%, oxygen saturation is less than 90% in 6-minute walk test. And here also, your echo right heart catheterization is important, because sometimes echo may miss a pulmonary hypertension in sarcoidosis patients. Now, pulmonary hypertension in sarcoidosis may have a precapillary or postcapillary component. Precapillary components are usually due to distal capillary loss of distal capillary bed leading to hypoxemia, or a granulomatous vasculopathy, which is associated with the classical pulmonary arterial hypertension with a pulmonary capillary weight tracer less than 15 millimeter of mercury. Now, post sarcoidosis patient may develop a pulmonary veno-occlusive disease or an extensive compression of pulmonary vein by lymph node or fibrosing mediastinitis, which is associated with post-capillary pulmonary hypertension. Again, a cardiac involvement in sarcoidosis patients with a left ventricular dysfunction may lead to a post-capillary pulmonary hypertension. But here, the pulmonary capillary weight pressure will be more than 15 millimeter of mercury. So right heart catheterization is important to check the hemodynamics and rule out the post-capillary or left ventricular dysfunction in sarcoidosis patient. So the treatment of sarcoidosis associated pulmonary hypertensions are generally sarcoid-directed therapy, that is glucocorticoids or steroid-sparing agents, and the studies showed that PH patient responds well with glucocorticoid when there is active granulomatous inflammation, and response is poor in fibrotic stage. Other supportive therapy like oxygen or management of comorbid conditions is important. pH-directed therapies are also evaluated in sarcoidosis patients, and lung transplantation is one of the important indication of transfer a patient or register a patient for lung transplantation in sarcoidosis. So there are many retrospective or open label cohort trial was done on epoprostenol, sildenafil, tadalafil, ambrisentan in sarcoidosis patients. All of them showed that these are associated with fall in pulmonary vascular resistance or decrease in mean pulmonary artery pressure. But the clinically significant outcome, that is 6-minute walk test, is not seen in all the trials, and all these studies are associated with higher discontinuation rate of the studied drug. These are the two randomized controlled trials done in sarcoidosis associated pulmonary hypertension on bosentan and riociguat. Both are double-blind placebo-controlled trial. The bosentan trial showed that although there is improvement in pulmonary artery pressure or pulmonary vascular resistance, there was no change in 6-minute walk distance. But the recently published riociguat trial showed that riociguat is associated with delaying in time to clinical worsening in sarcoid-associated pulmonary hypertension patients compared to placebo group. But you have to remember that the number of patients in both the trial is very less. Another important aspect to be discussed in sarcoidosis management, that 5 to 10% of sarcoidosis patients will progress to stage 4 or fibrotic disease. Whether we can use an anti-fibrotic like nintedanib or pirfenidone in an advanced stage 4 sarcoidosis patients. Now, in-build trial showed that the nintedanib is associated with annual fall in FVC in all subgroups of progressive fibrotic disease like hypersensitive pneumonitis, connective tissue disease, etc. But whether this is true with sarcoidosis also, we don't know. The decision to treat such patients with sarcoidosis with antifibrotic drug is not well standardized. The another option is the lung transplantation is advanced. But what are the indications of lung transplantation? I think the general indications of lung transplantation is also important for sarcoidosis patient also. The general indications of lung transplantations are that patients would have a higher risk of death due to lung disease within 2 years, with a higher likelihood of surviving at least 90 days after lung transplantation, and the higher likelihood of 5-year post-transplant survival from general medical perspective. The disease-specific indications for registering a patient with sarcoidosis are like fall in FVC more than 10% in 6 months, DLCO more than 15%, there is desaturation less than 88%, or a distance decreased below 250 meters in 6-minute walk distance testing, and the presence of pulmonary hypertension in right heart catheterization and hospitalization because of respiratory failures are the good indicator for registering a patient with pulmonary sarcoidosis. Lung transplantation. The lung transplantation is successfully performed in many patients with end-stage pulmonary sarcoidosis. Although it is performed infrequently, only in 3 to 5% patients of all transplant patients, and it is effective. The post-transplant 5-year survival in sarcoidosis patients are similar with the other type of lung transplantation like IPF and COPD. These are the summary of different treatment options in pulmonary sarcoidosis with their side effects. The most important or in the first line treatment is corticosteroid, which is associated, prolonged corticosteroid is associated with diabetes, hypertension, weight gain, and many other complications. We should monitor patients on long-term corticosteroid with a regular measurement of blood pressure, blood glucose, and bone density. Similarly, for methotrexate, we should check CBC, hepatic or renal function. For azathioprine, mycophenolate, mofetil, CBCs are important. And for infliximab or anti-TNF therapy, we should screen for TB to rule out LTBI. And also, we should rule out the active tuberculosis, and development of infection during the therapy is also to be followed up when patients are on this type of anti-TNF therapy. Thank you.
Share screen. So that was extensive, Sudeep. And as I said before, this does fit the bill of Novi Pulmonology Masterclass. You have covered all the topics, the controversies, the limitations, and I think both the talks of today, the student could have immense benefit. It is available in online post class in our website. So just follow the slides. Each slide can one have introspection on oneself. Just see the slide and just follow them, and really there's a very good coverage from both of you. Now, we have some questions. I'm not going to much questions because actually both the speakers have covered all the aspects in very detail. Just for recap. So, Sajal, you started with sarcoidosis, you said granulomatous. First you said systemic, then granulomatous, and then without a known cause. Is that true, Sajal? That's what you...
Yes, sir. Yes, sir. Yes, sir.
Okay. So if someone, what you ask from a student, from a student in Viva, the commonest clinical presentation of sarcoidosis in India. Sajal, please.
So there has been a recent article from AIMS Delhi by Dr. Karan Madang where he has analyzed a set of 370 patients. So he found that pulmonaries, like the important thing is pulmonary manifestations will be the most common, which can be, as I discussed, it can be TB-like presentation or ILD-like presentation. But extrapulmonary symptoms are the most important in the way that in some regions they'll be different, as Dr. Ghosh also talked about that in Japan, cardiac sarcoid is much more common than other areas. In India, I would say most common extrapulmonary presentations would be the eye, the skin, then hypercalcemia. So these three will be the most important. And then cardiac and neurosarcoid will be much less common. Lofgren syndrome is not infrequent. So we commonly come across the Lofgren syndrome or even asymptomatic hilar adenopathy. And in asymptomatic bilateral hilar adenopathy, it is mostly sarcoid. Rarely it is TB, very rare. So these are the most common presentations. So as I discussed, TB-like, ILD-like, those are the pulmonary and then the extrapulmonary.
I like this approach very much. TB-like, ILD-like, it's really great. Pulmonary and then the extrapulmonary. Sajal, so when someone gets hilar lymphadenopathy in a, say, 30 to 50 years age group, what are the commonest 3 or 4 DDs that you advise the students to follow? Hilar adenopathy.
So 3 most important would be tuberculosis, sarcoidosis, lymphoma. And if it's a smoker and a higher age group person, then I would say bronchogenic carcinoma. But in the age group that you told, sir, 30 to 50, especially if it's a non-smoker, then TB, sarcoid, and lymphoma. But we have seen that if it is bilateral hilar involvement and very symmetric and large nodes and less of symptoms, more of large nodes, then it is mostly sarcoid. With lymphomas, there'll be large lymph node masses, which will mostly be asymmetric. With tuberculosis, there'll again be single node, asymmetric nodes with some kind of hypodensity that suggests necrosis. So those are the few points where we can differentiate between the 3, but it is important to sample always in our country.
Now a little above. First, Sajal, then Sudeep. Sajal, is there any chance of combination, tuberculosis and sarcoidosis?
Sir, by definition, it is not there because if sarcoid is supposed to be of unknown etiology. So if you have documented tuberculosis, you cannot really label a patient with sarcoid. That is by definition. But what you are hinting at is a kind of syndrome where sometimes steroids are required in addition to ATT because there may be, say, extrapulmonary symptoms, for example, hypercalcemia. That can occur with tuberculosis, but it is rare. With sarcoidosis, it is much more common. You might have granulomatous hepatitis, wherein in the biopsy, you might not find any AFB or even the gene expert may be negative. The ALP may be very high. So, and in, say, the lung, you might find a gene expert positivity. So here the lung is behaving like TB and the liver is behaving like sarcoid, because liver involvement can also occur with miliary TB. But this kind of liver involvement with very high ALP and with miliary TB, the patient will be very sick. Sometimes the patient is doing okay, but in one organ, say, you find like TB-like features, and the other organ you find sarcoid-like features, and sometimes it might need a combination of ATT and steroids, but our policy is to avoid this combination as far as possible. So only very rarely, hardly I remember handful of cases where we have used this combination, and in fact, in no patient we have used it upfront. So one should always try to differentiate between the two disorders. And if it is really becoming difficult to differentiate between the two, and there is no organ-threatening manifestation of sarcoid, then it is better to go with ATT with a high index of suspicion of TB first. And then if the patient does not respond or a clear sarcoid manifestation comes along, then you can go with steroid.
I agree. So, Sudeep, just quick recap. What are the dermatologic manifestations, sarcoidosis?
As sir already explained in his talk nicely, the lupus pernio may be the most specific or a very particular symptoms for sarcoidosis that is not common in our country. What we see in our country is most of the time is the maculopapular rash. And another important thing, sometimes in acute presentation of erythema nodosum, we commonly see.
Sajal, you want to add anything?
Sir, you were silent, sir.
Sajal is silent.
Yeah, sorry. So I would like to add that one should differentiate between the specific granulomatous cutaneous manifestations and non-specific manifestations. So specific manifestations, as Dr. Ghosh also told, and I also referred to in my talk, that they may be papules, maculopapules, papulonodules, which may be there on the face, on the trunk, on the extremities. There can be plaques, which can also be there on scars. Old scars may suddenly develop a plaque. So these are all granulomatous lesions. There can be nodules, subcutaneous nodules, which may be granulomatous. But if you have erythema nodosum, that is a non-specific clinical cutaneous manifestation because it will not show you granulomas. So don't biopsy erythema nodosum because it will not show granulomas. If you have specific lesions, then you can biopsy and make a diagnosis.
So again, this is a good differentiation. Erythema nodosum is a non-specific manifestation, reaction, but there are more specific characteristic manifestations that should be taken for biopsy. Very well taken. And again, start with Sudeep, then Sajal, ocular manifestations. What do you commonly see, Sudeep?
We commonly see uveitis in eye as an eye manifestation of sarcoidosis. So this is the most common. Everyone should check or rule out uveitis before when we are suspecting sarcoidosis. The other manifestation of ophthalmological manifestation of sarcoidosis could be your drying of eyes. That's the involvement of lacrimal gland. It could your optic neuritis or optic nerve involvement, or it could be a granulomatous mass in your posterior to the eyeball. So these are the rare manifestations of ophthalmological manifestation of sarcoidosis. But I, in my clinical practice, always look for or refer patient to ophthalmologist to check for this uveitis thing in whenever I suspect sarcoidosis.
Sajal, anything?
Yes, I would agree with Sudeep that these are the common manifestations. So amongst uveitis, anterior uveitis is the most common, then followed by posterior uveitis, intermediate uveitis, and sometimes panuveitis. And in fact, in some series, panuveitis has been the most common. So uveitis is the most important, and you should always get an ocular screening. We also do an ocular screening for all our patients because sometimes uveitis can be silent and slowly it can become vision threatening. The other important thing is just have a look at the eye of the patient. Sometimes a red eye is often ignored by a patient. So yeah, no, just a naked eye look, that because sometimes I see the patient and ask him that you have a red eye, but the patient does not come up with that symptom. So they might be ignoring, okay, it's just a small kind of redness, so they might ignore. So just have a torchlight or even a simple look at the eyes and always ask about eye symptoms and then always refer to your ophthalmologist. So uveitis will be the most important. And there may be scleritis, there may be optic neuritis, as Sudeep told. There might be keratoconjunctivitis sicca with dry eyes, and there can be even lid granulomas. Orbit granulomas, all those features can be there. Corneal involvement is rare in sarcoid. That is important.
So Fajal, very short summarize. What imaging studies are routinely performed in the work of sarcoidosis?
So we do a chest radiograph, and as I told, a CECT, that is contrast enhanced CT, along with a thin section CT, that is 1 millimeter or 1.5 millimeter. I would slightly disagree with Dr. Ghosh that PET is a very good modality, because we have done a study with PET also where we found high SUVs, and those patients also sometimes completely resolve. So if you have the stage 1 disease, the patient is not symptomatic, and you have an SUV of say 14, 15, that does not mean that the patient requires treatment. But yes, granuloma, if there is any organ threatening or organ or disease causing organ dysfunction, then you need to treat. If there is quality of life impairment, then you need to treat. And if there's a lot of granuloma load, say for example, this stage 2 disease, a lot of nodules in the lungs, even with a normal PFT, sometimes you might need to treat if there are some symptoms. So it is a very individualized decision, and I would say that scoring like Walsh scoring are not mostly used in clinical practice. Even in the West, even the Western experts do not use it in the clinical practice. The guidelines do not talk about these scorings. It is mostly based on patient symptoms and quality of life impairment and organ impairment. This is how we decide when to treat a patient rather than any kind of specific scoring, because for the postgraduate, it may be very complex and they may not understand it properly. But yes, functional studies should be done. And if you feel there's a compromise, then you might decide to treat.
Okay, Sajal, but again, I feel what Sudip has done, that the students must know that these are the things that has been available. And so they should know about this, not necessarily practice every time. As for PET also, it's an individualized decision. We are not going PET for everybody. Sudip, any comment or adding anything?
So sometimes, sir, it's most likely the PET may not be good for all patients, but sometimes in very advanced stages, when we are very confused whether there is an active lesion is there or not, in that cases we may go for a PET scan before starting some advanced therapy like TNF or all.
It can be supportive at times. It is not indicated in all the cases. Take it.
Yeah, so I would just like to add that Sudeep has made a very important point. For example, if you have fibrotic sarcoid and if you do a PET study and the lung does not show an uptake, then you might not need a very high dose immunosuppression. But if the lung shows uptake, then you might not be sure that it is active or not, because even progressive fibrosis might be active on PET. So if there's very minimal activity in a fibrotic lung, then immunosuppression might not be required, or very low dose immunosuppression might be needed.
Okay, Sajal, it's up to you. What is the clinical relevance? Do we need to stage sarcoid? Do we? Yes or no?
I would say the scadding stages were more prognostic, and currently they are not one is that there is no stage to stage consecutive progression. So it is not stage 1 moving into stage 2 and 3 and 4 in every patient. So patients might present with stage 3 directly. They may remain stage 1, then resolve completely without treatment. So it does not really decide treatment. But yes, if I see a stage 3 patient, even if he is having mild symptoms and a milder lung impairment, I would have a low threshold to start treatment. But if I see, say, a stage 1 patient who is having acutely a lot of symptoms, I would still not treat him with steroids. For example, a lot of cough is there. I'll just give antitussives if there is stage 1 disease and no lung impairment. But yes, if stage 3 disease, even some bit of cough and dyspnea, I would like to treat with immunosuppressants. So that way it is useful.
So this is for the students, that this is a class and you need to get insight into the process. So staging is not necessarily clinically correlated every time, but it is good to know what are the different stages and how to interpret them clinically. Okay, this one. I will start with Sajal, then Sudip. Any role of CPET in the workup of sarcoidosis?
Personally speaking, I do not use it much, but I do see a role in some patients. For example, sometimes it might be difficult to attribute the patient symptoms to whatever we are seeing on the CT and the PFTs. So the PFT may be normal, but the patient might be having dyspnea, So we really need to find out whether the gas exchange is being affected. Sometimes DLCO doesn't get appropriately done, or even that is very borderline. So CPT might help you in deciding why a particular patient is having dyspnea. Is it deconditioning only? Is it pulmonary hypertension? Is it lung involvement? Or is it sometimes just fatigue, which is leading to the sensation of dyspnea? So there it becomes important in certain patients if you are not able to find out with the basic tests like CT scan, spirometry, and DLCO.
Sudeep, anything? You need not
Like,
track.
I am also not using CPAT in sarcoidosis patients, but as in other cases of interstitial lung disease or any case of chronic lung diseases, I use 6-minute walk distance as a surrogate for exercise testing. So in that case, when we suspect there is a disproportionate desaturation, or your PFT and the 6-minute distance or desaturation is not matching, then I suspect pulmonary hypertension. So that could be one thing I can suggest.
Okay. Actually, we have not almost, we have over completed our allotted time. So I will just, this one was the last. Lung transplantation, I think Sudeep has covered it. Sajal, you want to add anything on it?
No, sir. I think Sudeep has covered it.
But it very well in the lung transplantation. So before we, let me see whether there is any chat or not. No. Anything else? No, not much. So we can go again there. Now before we complete, Sajal, just general prognosis of sarcoidosis. In general, all the patients you see, it's a referral center. What is the prognosis of sarcoidosis in India? Is it different from the West or anything like that? Sajal.
Sir, I do not think it is much different in India. I would say that differentiation from tuberculosis becomes the most important because sometimes on the basis of X-ray, without doing even a sputum examination, physicians do treat patients with anti-tuberculosis medication, especially out of the DOT, without the DOT RNTCP treatment. And such patients are often not diagnosed appropriately with sarcoid for a long period of time. And then they develop fibrotic sarcoid. So that is one thing where in India we might lag in terms of giving appropriate care to such patients because we confuse everything with TB. So always this index of suspicion should be there. One should always go for a microbiologic diagnosis. Otherwise, I would say that stage 1 disease has a very good prognosis if extrapulmonary involvement is not there. Stage 2, again, mild lung involvement, good prognosis. If the duration of symptoms is prolonged, then the prognosis keeps on worsening because then microscopically fibrosis sets in, especially if lung involvement is there. So there, the quality of life may be, the disease may be irreversible, the patient may have persistent dyspnea, the quality of life may be impaired, even the longevity is affected if the patient develops significant advanced stage 4 or fibrotic sarcoid. But it is better than other ILDs. Even a fibrotic sarcoid patient will have better longevity and slightly better quality of life as compared to patients with other ILDs.
What is the percentage of relapse that you have seen, Sajal?
So we did a recent study which is going to be published soon, where we compared a 20 milligram initial dose and a 40 milligram initial dose of prednisolone, and we gave it for 6 months. It was an RCT. So there we had the relapse as the primary outcome. So in both the arms, we found about 40 to 45% relapse rate in 1.5 years of total duration. That is 6 months of treatment and 1 year of observation. And these were all patients who really required immunosuppression. We excluded those patients who would improve with observation only. So we excluded maybe half of the patients we screened, we excluded because they had mild disease. So there the relapse rate is quite low. When we are not requiring immunosuppressive treatment, then the relapse rate is quite low. If a patient requires immunosuppressive treatment, then I would say a 40% relapse rate.
I understand. practically you are differentiating. So the mind, actually we had an idea that in total sarcoidosis the relapse rate would be hardly 5%, something like that. But you are telling
I
them
would say, sir, maybe 10 to 20% cases, because about 50% of our patients do not require treatment, and they may be relapsing maybe 5% of the times, but 5 to 10%, I would say. But if somebody requires treatment, so 40%, so maybe about 10 to 20% might be the figure, sir.
Okay, Sudeep, anything to add on this? Sudeep?
So nothing new to add from my side, sir.
So we have two questions. If you can take it up, please.
There. Okay, now one said IGRA can help to rule out sarcoidosis. Any comment on this, Sajal? Some doctors say IGRA can help to rule out sarcoidosis. Yes, your comment.
I would not agree with that, because a positive IGRA might still occur with sarcoid. So it may be latent TB, but a patient with latent TB also can develop sarcoid, which might need immunosuppressive treatment. So it's it's very difficult to understand the relationship between mycobacteria and sarcoidosis. Sometimes even in the clinic, it is very perplexing. So I think more research is needed in this area, because the real pathophysiology behind this is very difficult to understand. But I would disagree with this thing that IGRA can help rule out sarcoid.
I fully agree. This cannot be a blanket statement. And being a very old physician, I will suggest the composite clinical picture is very important with the supportive evidence. And actually, we use Mantoux test all along with our scenario. Practically, in those days, 30 or 40 years back, the combination of SSE high with Mantoux negativity was more sensitive in diagnosing sarcoidosis. That was practiced about, say, 40 years back. Okay, the second question goes to Sudeep. In which group of patients we advise only short-term steroid therapy? He has commented 3 months. So is there anything to it? 3 months, short steroid therapy, any group of patients, Sudeep?
No, sir. In my practice, I usually give at least 6 months.
Okay, over to Sajal.
Yeah, I would agree with Sudeep. For most patients, it is 6 months minimum, and mostly it is 9 months or more. But yes, we have been trying in a few patients a very low dose kind of steroid, maybe 10 milligram for 3 to 4 months. If the main problem is quality of life impairment, for example, a lot of cough which is not responding to antitussives, this kind of a thing. If there is no particular indication of organ dysfunction or threatened life, which needs a higher dose and higher duration of treatment, then in some patients. But I also use a lot of NSAIDs in patients with pain, in patients with fever, and steroids are mostly not required in such patients with mild disease. But yes, mostly it will be a higher duration. Short duration is kind of, the guideline has said this time, the BTS guideline, that you might use a low dose for quality of life purposes or for simpler symptoms. But it is not widely accepted, it is not widely practiced, and does not have evidence.
Okay, so practically this is an individualized decision. 3 months is usually not the practice, even we do not practice this 3 months. But again, we taper 6 months and then down to very low level by 1 year. But Sajal, this brings to another inhaled corticosteroid. When do you use it? For sarcoidosis?
Sir, its evidence is like very controversial. In some studies there was no benefit at all. In a few studies there was some benefit in, say, symptoms or relapse prevention. So if there is obstruction, I tend to give ICS with LABA, especially once I have tapered down oral corticosteroids. Then I continue those patients with airflow obstruction on ICS and LABA. Sometimes there is comorbid asthma. So if there's clear polyphonic wheeze or previous history, there is comorbid asthma which will require ICS LABA for the asthma treatment. And otherwise, rarely I've used ICS when I taper down steroids to 0. Rarely I have used ICS just for some symptoms, for example, a little cough. So it is a kind of individualized approach, and the evidence is conflicting.
Sudeep, ICS?
As I totally agree with Dr. Dhuria, sir.
Okay. So practically, I need to summarize both that what Sajal has said, that sarcoidosis is systemic, granulomatous, and of unknown etiology. And what Sudeep said, that the treatment you have to decide both the treatment benefits and the side effects of the drugs. And then naturally, okay, I fully support that methotrexate is a very good drug for sarcoidosis with very little side effects. I am not very convinced with mycophenolate in the long run, but of course, steroids remain the mainstay, primary component of treatment in sarcoidosis. So we have covered the whole thing, and again I thank first our audience who have been there throughout this 90 minutes or more. Sajal, thank you for coming and joining us, and hope we will be communicating with again later. And Sudeep, he is our household lad, so we can disturb him anytime. Yes, Sudeep? Okay. So thank you both, Sajal, Sudeep, and hand over it to the logistics. Is somebody from Lupin there? Is Raja there or anyone? No?
Yes, Pranali. Yes, Pranali.
Pranali, you can give thanks to the team.
Yes, sir. So thank you so much. I thank each and every delegate. I also thank Dr. Sajal Duri and Dr. Sudeep Ghosh for their extensive talk, which they have summarized. It has been an enlightening session for all the delegates, I'm sure. And it was a very knowledgeable evening for all of us. So thank you so much. Thank you, sir, for curating this wonderful program for chest PGs. So Dr. Professor A.G. Ghoshal, sir, all credits to you.
Thank you
And
all.
Thank you, sir.
Thank you. Thank you.
Good night.
Good night. A card number.